please.
Going live.
Very good. Thank you. Alright. Sige.
Tama, no? May lumabas ng notification, Doc.
Meeting is now streaming live.
Again, balik tayo dun sa testing ng ng tawag dito, live streaming. Sige. Gmail. Balik tayo sa balik po tayo sa testing ng screen sharing. The resident will be presenting calvarial tuberculosis. Nandito ba? Please make yourself available. Nandito po ba?
Good afternoon po. Yes po.
Yes, ayun, doktora, pwede testing natin, pwede yung screen sharing mo?
Okay po, sir.
Testing lang, kahit first slide, second slide, third slide.
Good day. Yung video, sir.
Sige. Kahit lang, 5 seconds lang. Video yan, no?
Good day. Today I will present calvarial.
Okay. Sige. Talaga bang medyo may happy? Yes,
Good
yes, ma'am.
afternoon. Doc JC Matanda.
Dr. JC, yes po.
Manggagaling yung videos from Dr. Yakapin. So, nakakompile na yun. So,
Okay, Dr.
dire-diretso na.
Sige, Doc.
The contestants will just be, they need to be present for the Q&A also. Para hindi na sila mag-share screen. Thank
Yes,
you.
Doc. Doc, thank you.
Turn on the videos pag for the contestants. Just turn on your videos pag Q&A na. After each after your video presentation, magka Q&A. So they have to turn on their video.
Okay, roll call lang ulit. Calvarial tuberculosis. Sige, natawag na kanina. Para laparoscopic cystectomy, yung resident na 50%, nandito ba? Lapit na tayo mag-start. Laparoscopic cystectomy with omentopexy.
Nandito po.
Yes, thank you. Number mistaken identity, case of appendiceal mucinous neoplasm representing as ONG. Nandito.
Present, sir.
Thank you ulit. Sebaceous carcinoma. Nandito rin. The residents will be presenting sebaceous carcinoma of the sinonaso-orbital area. Again, nandito ba? Okay. Sige, mamaya ulit. Yung soft tissue and left temporal case, 1 year and 7-month-old female, Filipino male. Nandito?
Yes po, sir. Present po.
Thank you. Thank you, Doc. Yung president who will be presenting the spontaneous splenic rupture, nandito rin ba?
Present, sir.
Okay, nice. Ulitin ko, isa na lang ang nawawala sa atin, yung sebaceous carcinoma. Nandito rin? Nandito po? Medyo missing pa tayo ng isang resident. We will wait for a while. Baka siguro na-delay lang sa pagla-login. Play lang natin. Yes. Oh, walang sound. Kaya wait lang.
Drug Company Incorporated. Here for you every step of the way.
When it comes to treating bacterial infections, you gotta know what you're up against. Because sometimes, it only takes one if done really well. Monowell. Monowell is a broad-spectrum bactericidal antibiotic indicated for the treatment of infections caused by susceptible strains of gram-positive and gram-negative pathogens, both aerobic and anaerobic. The unique molecular structure of Monowell gives a particularly high degree of resistance to beta-lactamases, a major mechanism of bacterial resistance to penicillins and cephalosporins. Monowell is indicated for the treatment of gynecological infections, septicemia, endocarditis, respiratory tract infections, bone and joint infections, and skin and soft tissue infections. It is also indicated for the prevention of post-operative infections in patients undergoing surgical procedures. The power of one. Get the strength and reliability with monotherapy with Monowell.
Fighting strong, without hesitations. Confidently, defeating the enemy. Actively combating infections head-on with Bactiv. Bactiv is an antibacterial combination of amoxicillin and the beta-lactamase inhibitor clavulanic acid. This association makes Bactiv an antibiotic agent with a broad spectrum of activity against a wide range of bacterial pathogens. Bactiv is indicated for short-term treatment of upper and lower respiratory tract infections, genitourinary tract, and abdominal infections, and skin and soft tissue infections. Bactiv is available in 625 milligram film-coated tablets, 1 gram film-coated tablet, 500, 100 milligram powder for injection, and 1 gram 200 milligram powder for injection. Achieve victory in the combat against bacterial infections with Bactiv.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. It is also indicated for the management of acute pain and dysmenorrhea. Coccidia is also used as an adjunct therapy to reduce the number of adenomatous colorectal polyps in patients with familial adenomatous polyposis. Coccidia is available in 200 mg and 400 mg capsule. When in pain, take Coccidia. It's programmed to take over pain. It's not flowing as it should because of BPH? Let it stream naturally. Releasing is easy with Tamzor. Tamsulosin hydrochloride, Tamzor, is an alpha-1 adrenoceptor blocking agent indicated for obstructive symptoms in men with benign prostatic hyperplasia, BPH. It works by releasing smooth muscles in the prostate and bladder, which helps improve urine flow and reduces symptoms of BPH. Tamzor 400 mcg prolonged release capsule is recommended to be taken once daily for the treatment of the signs and symptoms of BPH. Let it flow with ease with Tamzor.
The new normal is just a new phase in this walk of life. Like all of life's phases, it is best embraced and faced head-on. Life is precious and even more beautiful. Cathai Drug's mission to deliver quality medicines that are within reach of every average working Filipino continues and intensifies. With you as our valued partners, we will continue to provide quality healthcare solutions for every Filipino household. Anti-infectives, Bactiv, Monowell, Protozol, Widox, and Silverderma. Anti-neoplastic agent, Kalubia, alpha-1 adrenoceptor blocker, Tanzor, anti-osteoporosis, Bondros, non-steroidal anti-inflammatory, Coccidia. Your partner in facing life's health challenges. Cathai Drug Company Incorporated. Here for you every step of the way.
When it comes to treating bacterial infections, you gotta know what you're up against. Because sometimes, it only takes one if done really well. Monowell. Monowell is a broad-spectrum bactericidal antibiotic indicated for the treatment of infections caused by susceptible strains of gram-positive and gram-negative pathogens, both aerobic and anaerobic. The unique molecular structure of Monowell gives a particularly high degree of resistance to beta-lactamases, a major mechanism of bacterial resistance to penicillins and cephalosporins. Monowell is indicated for the treatment of gynecological infections, septicemia, endocarditis, respiratory tract infections, bone and joint infections, and skin and soft tissue infections. It is also indicated for the prevention of post-operative infections in patients undergoing surgical procedures. The power of one. get the strength and reliability with monotherapy with Monowell.
When you try your best but you don't succeed, when you get what you want but not what you need, when you feel so tired but you can't sleep, stuck in rivers,
and the tears come streaming down your face when you lose something you can't replace, when you love someone but it goes to waste. Could it be worse? Lights will guide you home and ignite your bones, and I will try to fix you. And high above or down below, when you feel love, you let it go. But if you never try, you'll never know just what you were. Lights will guide you home and ignite your bones, and I will try to fix you.
Good evening. Last call, isa pang call doon sa resident na will be presenting yung sebaceous carcinoma of the sinonasal orbital area. Nandyan ba siya? Mali ba yung hinahanap ko? Again, last roll call. Calvarial tuberculosis. Si Doktora nandyan, mag-present.
Yes po, sir.
Okay, lap cystectomy with omentopexy, nandito.
Yes po.
Thank you ulit. Mistaken identity, case of appendicitis sinus neoplasm.
Present, sir.
Sige, sebaceous carcinoma of the sinonaso-orbital area. Missing tayo na isa. Soft tissue and left temporal bone. Histiocytosis nandyan. Okay. Andito?
Yes, sir.
Doc? Oh, yan,
Yes, sir.
tama. Thank you. Spontaneous splenic rupture and a pulmonary arteriovenous malformation. Andito, ano?
Present, sir.
Sige. So, may kulang na isa na lang. Mag-start tayo at 5:30. 8 minutes na lang.
You hold and ignite your bones, and I will try to fix you.
When you try your best but you don't succeed, when you get what you want but not what you need, when you feel so tired but you can't sleep, stuck in rivers. Lights will guide you home and ignite your faith.
Good evening, everyone. We'll be starting in 4 minutes. Yung isang yung isang presenter po natin ay presently unavailable. So, we'll do with the present na individuals na nandito ngayon. So, sa participants, good luck po. And mag-start po tayo in 4 minutes.
And ignite your bones, and I will try to fix you.
And high up above or down below, when you feel in love, you let it go. But if you never try, you'll never know just what you want.
Um, so hopefully na-enjoy nyo po yung ating video presentation ng FixU, care of ating PCS and PSGS various fellows po na very talented. Hopefully every residents at saka interns na nandito po ngayon ay maging part ng family someday. So we'll be starting na po. Thank you. So welcome everyone sa ating annual research contest, particularly yung interesting case category. It's brought to you by the Philippine College of Surgeons and the PSGS Southern Tagalog Chapter. I'm Dr. Mark Loren Bueser, yung moderator nyo ngayon. I'm currently in San Pablo City, General Surgeon also. So also a new fellow lang ng FPCS. PCS. So let's start the ball rolling. Let's start with prayer. So everyone, let's put ourselves in the presence of the Lord. Silence for everyone.
Our Father who art in heaven, hallowed be thy name. Thy kingdom come, thy will be done, on earth as it is in heaven. Give us this day our daily bread, and forgive us our trespasses, as we forgive those who trespass against us. And lead us not into temptation, but deliver us from
Mataas ang buga, maya't-maya ang putok ng bulkan.
The Taal volcano has turned the landscape monochrome.
Chinese health authorities are still working to identify the virus behind it.
The confirmed case arrived in the Philippines from Wuhan, China.
COVID-19 can be characterized as a pandemic.
Mga kababayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, telas ng silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulupin, di ka pasisingil, sa nagagang tutok sa simoy at sa langit mong pagaw, ay hinagang tulang awit sa paglayang minamahal. Ang islang ng matawad mo'y tagumpay na nagtitindig, makituwin at araw niya kailan pa may di magtitindig. Luman ang araw ng walhagit pagsinta, buhay langit sa piling mo.
Yeah. So again, good evening, everyone. So as a welcome for everyone, PSGS President, Dr. Mike Lowenko will be giving us some opening remarks. Uh, Good evening, sir.
Good evening. Good evening. Can you hear me?
Yes, sir. Loud and clear po.
Okay, so good afternoon, fellows, residents, and friends of the PCS, PSGS Southern Tagalog chapter. Today we will be holding our third interesting case research contest. What makes this special this year is that we will also be having a separate category for the descriptive as well as the analytical researches in the coming weeks. This is a continuing endeavor started by our past president, Dr. Froilan Dacumos, which up until today, he is continuing to guide us in making this a better research activity. Thank you, sir. And thank you to the judges for accepting our invitation, Dr. Marilu Fuentes, Dr. Wesley Reyes, and Dr. Mike De La Paz. We'd also like to thank our sponsor, Cathay Drug, through Michael Jaramillo, Alan Nunez, and Dion Malapanan. And so STC has continued to produce outstanding researches that win national and international research contests and may become publication worthy material. Okay. Research is also ingrained in the training culture of our residents, such that eventually they make evidence-based surgical decisions throughout their surgical careers. We hope that this annual research contest brought about by the Southern Tagalog chapter will have an impact for our trainees to strive for better and quality research outputs. With that said, good luck to all our contestants, and thank you for attending this event. And we will now proceed with research proper, or the explanation of the guidelines. Thank you.
Thank you, Sir Mike. Our PSGS Secretary, Dr. Janet Carion, will now be presenting the reviewing the guidelines of the contest.
Thank you, Dr. Mike. Good evening, everyone. So I'll be presenting to you the guidelines set by the technical working group for the interesting case category. So for the participants, we are allowed only one case report for each institution, and the presenter should be a current resident trainee of the corresponding institution and should be the primary author. We also have guest participants, part of the contest. These are participants from training institutions that are not part of Southern Tagalog chapter but wish to participate in this activity. They will not be included in the main competition. However, their presentation will also be judged against a co-guest participant. Next, please. So the deadline of submission was last October 23 with the following format. And we ask all participants to not include any identifying marks or names of authors nor the institution in their papers. Next, please. So the contents of the manuscripts are the following: abstract, introduction, pertinent features and workups done, discussion, conclusions and recommendations, and literatures they cited. Next. So the case should be a surgical case. All of the contestants have submitted their pre-recorded oral presentation with a maximum of 8 minutes. The deadline was set at November 2, 2021, and the sequence of presenters was determined by digital draw lots last November. Of presentation, next please. are the following. Okay, next please. So for the Q&A portion, 3 minutes will be allotted per judge after each presentation. No questions will be entertained from the general audience. The contestant is not allowed to include again any of his slides, the names of the authors and the institutions he or she is representing, and the decision of the Board of Judges is final. Next, please. So for the pre-recorded oral presentation, a template was sent to all the participants, and we asked them to place the picture situated on the left upper corner of the screen while speaking, and all participants should wear a white coat in the oral presentation. Next, please. So the criteria for judging, all written papers that were submitted are prejudged already, comprising about 70%. The following are of abstract, that means overall clarity and conciseness of abstract, that is 10%. Importance of the case, that is author's statement regarding rarity of the disease. Uniqueness of presentation, or importance in clinical practice, that is 20%. Volume of work, this 20%, that means completeness of workups, documentation and follow-up. Conclusions, 20%, that is appropriateness of clinical and research implications. For the oral presentation, that is 30%, the overall presentation would be graded as 10%, ability to answer questions, 20%. Next, please. However, we have penalties. Late submission of manuscript, that is 1 point per day. Late submission of pre-recorded video, 1 point per day, and not following any part of the set guidelines. So each violation would incur about 1 point deduction. Next, please. So for the prizes of the winners, first place would win 10,000 pesos, second place 7,000 pesos, and third place 5,000 pesos. Thank you. That's all. Thank you, Dr. Mark.
Yes, thank you, Ma'am Janet. Maraming salamat po. So, our research coordinator, Dr. Clarence Yakapin, will now be presenting the panel of judges.
Thank you, Mark. Good
Thank you,
evening,
sir.
everyone. It is with great honor that I present to you our distinguished panel of judges for this evening's research contest. Our first panelist earned his medical degree at the University of Santo Tomas Faculty of Medicine and Surgery. He did his surgical residency training at Amang Rodriguez Memorial Medical Center, where he was also the chief resident. He later took his fellowship in minimally invasive surgery at the Asian Hospital and Medical Center. He is currently taking his master's degree in hospital administration at the University of Santo Tomas. He is a fellow of the Philippine College of Surgeons, PSGS, PALES, and American College of Surgeons. He is the chair of the Department of Surgery of Oriental Mindoro Provincial Hospital, and the founder and committee in the construction of both Mindoro Medical Center in Calapan City and the Holy Infant Savior Somas Medical Center in Oriental Mindoro. He's an innovator and a researcher. Two of his innovations, the Endoloop suturing device as well as the Zero BDI app that he developed, won first and second place respectively in the Technical Innovation Contest of PALES in July 2021. He won the Best Mentor-Mentee Video Presentation in Korea during the Korean Society of Endoscopic and Laparoscopic Surgeons Convention in 2020 for his presentation on minimally invasive surgery training using traditional culinary art. His research in the fun, innovative, nice, and enthusiastic way of learning laparoscopic skills through endoscopic painting as a laparoscopic box training exercise was presented in SAGES in 2016 and won the Harith M. Hassan Award for Best Presentation Promoting Education or Training in 2016 in the Netherlands. It was also presented as a TEDx Spotlight presentation during the same event. Ladies and gentlemen, let us please welcome Dr. Michael Dennis de la Paz.
Hi, good evening. Thank you very much.
Mike, Southern Tagalog ka ba? Wah, Mindoro ka pala.
Initially kasi sa Metro Manila ako pero lilipat po talaga ako dito.
Yes, we
I need
welcome.
endorsement lang. Yes po, Doktor. Sa Pales, Southern Tagalog po ako.
Thank you, Mike.
Thank you, Sir Mike.
Our next panelist graduated medicine from the University of the East Ramon Magsaysay Memorial Medical Center. She finished her surgical residency training at the Medical City and proceeded with her fellowship training in advanced minimally invasive surgery at the National University Hospital in Singapore. She is a fellow of the PCS, PSGS, and PALAS. She is also an examiner of the Philippine Board of Surgery and a member of the Asia Pacific Hernia Society. She is currently the training officer of the Department of Surgery of the Medical City in Pasig City. She has presented 2 papers during the 6th International Congress of APHS in Seoul, Korea in 2010. These were the single-port endolaparoscopic surgery for totally extraperitoneal inguinal hernia and a case control study on comparing different methods of fixation on endoscopic TEP repair for primary inguinal hernia. She has several publications, including one in the journal Hernia on single-port endolaparoscopic surgery for totally extraperitoneal inguinal hernia, a critical appraisal of the chopstick repair, and contributed several chapters in the 2nd edition of the Manual for Endolaparoscopic and Single-Port Surgery. Ladies and gentlemen, let us please welcome Dr. Mary Lou Fuentes. Good evening, ma'am.
Good evening.
Good evening, ma'am.
Yeah.
Our third panelist earned his degree from the Davao Medical School Foundation and took his surgical residency training at Davao Doctors Hospital, where he was the chief resident. He proceeded with his fellowship training in colorectal surgery at the National University Hospital in Singapore. He's the past president of the PSGS Davao Southern Mindanao chapter, past chairman of the Disasters Committee of Davao Doctors Hospital. He's currently the secretary of the Department of Surgery and a member of the training committee of Davao Doctors Hospital. He's also a faculty of Davao Medical School Foundation. He has won several awards. His research has won several awards. He won 3rd place in 2004 for his research on the accuracy of PSA as screening method for prostate carcinoma, a retrospective study. 2nd place in 2006 for his research on the accuracy of ultrasonographic findings in detecting thyroid carcinoma based on echogenicity, a retrospective study. And his paper on the use of methylene blue in preventing postoperative adhesions, a randomized controlled single-blinded study, won 3rd place in the Interdepartmental Research Paper Contest and also 3rd place in the PCS Tripartite Convention in Bacolod in 2007. Ladies and gentlemen, let us please welcome Dr. Wesley A. Reyes. Good evening,
Hi,
sir.
good evening.
Good
Good
evening,
evening,
Sir
Dr.
Wesley.
Lowenko. Good evening, Southern Tagalog chapter. Thank you for having me.
Thank you very
Bye.
much.
Good evening, bye.
At this point, I would like to thank the judges for sharing their time and their expertise for our residents and for our society. I'm confident that with the help of our panel of judges, we will have a lively and educational discourse this evening as we enrich ourselves with updated surgical knowledge and promote surgical research to our residents as well. Mark, you may now proceed with the video presentations of our residents.
Yes, sir. Opo. Before nga pala po tayo mag-proceed sa video presentations, please check po yung attendance link at the chat box. Don't forget to sign up for this attendance. So, okay, we'll be starting with the video presentations of the residents.
Rare disorders don't usually combine our day-to-day clinical grind, and such is no excuse in gaining adequate knowledge to be able to correctly diagnose and treat them. Good afternoon. I'll be presenting a case of Langerhans cell histiocytosis, a rare disorder involving the antigen-presenting cells of the body in a pediatric patient. This is EC, a 1 year and 7 months male from Tanza, Cavite, a Roman Catholic, who presented with a mass at the left temporal area. History of the present illness revealed a 5-month history of non-painful mass at the left temporal region with gradual enlargement of the mass at interim. There was no associated signs and symptoms noted for the patient. Consult was done at a tertiary hospital, and after workup and subsequent multidisciplinary discussions with pediatric surgeon, pediatric neurosurgeon, and pediatrician, the patient was admitted to undergo an operative procedure. Patient did not present with jaundice, rashes, petechiae, weight loss, abdominal pain, and distension, melena, hematochezia, or hematemesis, and has no history of trauma. Past medical history and family history were unremarkable. Patient is a mother with an eventful prenatal to postpartum course with no known chemical, radiation, or teratogenic drug exposures during pregnancy. Vaccination for the patient was complete for age, with parents noted to be non-smokers. Patient belongs to a family with below average socioeconomic status. On physical examination, patient has a normal body habitus with normal activity with a 1.5 cm by 1.5 cm fixed, firm, well-circumscribed mass at the left temporal region. Other systems examination were unremarkable. An initial complete blood count revealed leukocytosis with lymphocyte predominance for the patient, with other laboratory findings being unremarkable. A cranial CT scan was requested, which revealed an extracalvarial mass at the left temporal region with left temporal bone erosion. And with this, the patient underwent excision of left temporal bone and soft tissue mass. With 1.5 cm by 1.5 cm solitary, non-encapsulated, gelatinous, yellowish tan brown soft tissue mass. This was sent for histopathologic examination that revealed proliferation of cells of pale or vacuolated cytoplasm and ovoid or uniform vesicular nuclei with occasional nucleoli and nuclear grooves, which are admixed with inflammatory cells consisting primarily of lymphocytes and eosinophils, with accompanying giant cells and areas of necrosis. This is consistent with Langerhans cell histiocytosis, and hence patient was advised for CD1A and S100 protein to confirm its diagnosis. Patient was also advised consult to pediatric hematologist oncologist for possible initiation of chemotherapy, both of which awaiting for compliance. To discuss, Langerhans cell histiocytosis is a rare disorder of unclear etiology and pathogenesis involving uncontrolled stimulation and proliferation of dendritic cells, predominantly of Langerhans cells. It has relatively low incidence of 2 to 5 cases per million individuals yearly, with incidence in children less than 15 years old of 4 to 5 cases per million per year. Currently, there is no established epidemiology to our knowledge of LCH or Langerhans cell histiocytosis in our local setting, and hence reporting of these cases is paramount and important to establish one. Risk factors which correlates with LCH or Langerhans cell histiocytosis involves family history of cancer, parental exposure to solvents, metals, granite or wood dust, previous perinatal infections, Hispanic race, lack of childhood vaccination, and the one that is present in our patient, low socioeconomic status. The disease may present as a single site or multiple site involvement. The most commonly involved sites would be the bone and the skin. Other presentations may involve the lungs, the lymph nodes, the GI tract, the thyroid gland, central nervous system, thymus, pituitary gland, and even the liver, the spleen, and the hematopoietic system. Presentation varies depending on the site of involvement, and so workup is tailored depending on the patient's clinical manifestations. As for the patient who presented only with left temporal mass, initial laboratory workups with cranial CT scan may be sufficient. The cornerstone of diagnosis of LCH or Langerhans cell histiocytosis involves not only identification of characteristic clinical features, but also histopathologic and immunohistochemical studies to confirm the diagnosis. The most sensitive and specific for the diagnosis of LCH includes the CD1A NS100 protein, hence requested to our patient. Other markers which suggest LCH as a disease includes your HLA-DR and anti-langerine or CD207. Several treatments are available for the disease and is used depending on the extent and site of the disease. This may include phototherapy, intralesional steroids, radiotherapy, topical and/or systemic chemotherapy, and surgery. For our patient who only has a single system involvement of temporal bone and surrounding soft tissue, an excision with chemotherapy is recommended, and this includes at least 12 months of vinblastine prednisone therapy, starting from weekly vinblastine for 7 weeks with daily prednisone for 4 weeks, then tapered over 2 weeks. This is then followed by prednisone given for 5 days, every 3 weeks with a vinblastine injection. For the prognosis and outcome of Langerhans cell histiocytosis, spontaneous regression of the disease is expected in up to 20% of patients. The remaining set of population will require treatment. Prognostic factors for the disease, which correlates with the mortality, includes your extent of the disease at presentation and initial response to the therapy. Younger patients with localized LCH may have prolonged lifespan as compared to those with disseminated ones, with approximately more than 50% of the latter resorting to mortality. For those who have been treated and do not have more lesions at 12 to 24 months, a full recovery can be expected. And as for our patient who only presented with a single site involvement, provided that he complies with the recommended course of treatment and management, a favorable prognosis is expected. Ideally, these patients should have follow-up evaluation after treatment and should include skeletal radiographic survey, gastrointestinal studies, MRI, or CT scans based on the location and number of involved sites at diagnosis. Currently, there were few reported cases of LCH in the country with no known established epidemiology, at least to our knowledge, and standardization of diagnostic and treatment protocols to the local setting for this disease remains challenging. And therefore, this emphasizes that reporting of these cases is again important to be able to achieve such goals. In conclusion, Langerhans cell histiocytosis is a relatively rare disorder with low incidence and with varying clinical presentations. Clinical features accompanied by histopathologic and immunohistochemical studies are required to diagnose the disease. Several treatment options are available, and prognosis depends on several factors with survival closely linked to the extent of the disease and presentation, and initial response to the therapy. Reporting of such cases is encouraged to achieve establishing epidemiology and standardization of diagnostic and treatment protocols. That would be all. Thank you po.
Thank you, Doc. So we'll be proceeding with the next case.
We'll proceed with the Q&A muna, Mark.
Then, sige. Okay, sir.
So, refresh ko yun.
Thank you, sir.
Yes,
Opo.
the participant to turn on his video.
Doc, makiki-on ng video.
Good afternoon po. Good evening po.
Good evening, Doc. So we'll be proceeding with the question and answer for the presenter.
Can I go first?
Yes, sir. Sir Wesley, yes po.
Hi. Hi, good afternoon. Thank you for that presentation. No? My question is, did the patient receive any adjuvant therapy?
To my knowledge, sir, this patient did not receive any adjuvant therapy po, sir.
Was it recommended or is there, was it recommended?
Based on what I've read, sir, there's no current recommendation for new sir, can you repeat the question, sir? Sorry po, sir.
The first question was, did the patient receive any adjuvant therapy? And if not, was it recommended?
Currently for this patient, sir, this patient has not yet received adjuvant therapy, sir. To confirm the diagnosis of LCH, sir, we must get results from S100 and CD1A po, sir, to confirm the diagnosis, sir. If this patient has not yet does not have yet these markers, sir, and if proven, sir, LCH, uh, with the presentation of the patient having an involvement of the temporal bone, sir, aside from the excision, sir, based on my readings po, sir, an adjuvant therapy is recommended po, sir. Mainly vinblastine po, sir, and prednisone po, sir. Therapy po, combination, sir.
That's all. Thank you.
My
Thank
turn,
you.
Wesley.
Yes,
Um,
Dr. Ra, may proceed
yes.
po.
Good evening,
Sige, ma'am.
Kevin.
Good evening po.
First of all, comment lang. I would like to congratulate because you already stated the objective and treatment plan dun sa iyong paper. So, dun sa abstract pa lang nakita na siya. But I suggest that you add additional pictures kasi diba, this is a rare case. So, everyone is interested how it looks like before, during, and after surgery. So, it is best that you include kasi walang intra-op pictures dun sa sinend mo na paper and as well as your presentation. Now, my question is, di ba it was stated that Langerhans LCH has a tendency to involve other organs. So how did you assess yung other organ involvement?
Ideally po, Doktora, other our organ systems must be evaluated po, Doktora. For this patient po who presented with the temporal area mass po, Doktora, with normal body habitus po, currently po there's no suspicion of any other organ site involvement. Although, ideally, ma-work up pa rin po siya doon, Doktora. To my knowledge po, Doktora, this mass is not thought to be an LCH at first, Doktora. And so, limited pa po yung workup for the patient. But this patient, on follow-up po, with the result of the histopathologic examination po, Doktora, has been advised for further workup nga po, Doktora. This may include, Doktora, skeletal surveys po since the disease has propensity to go with the bones, no? And even other organ systems po, Doktora. This patient also may be required to have initial imaging studies po. For instance, an ultrasound po, Doktora, to just rule out the possible involvement of, say, the liver, other intraperitoneal structures po, Doktora.
Okay, last question. Di ba usually ang patients, are you in a government hospital?
Yes po, Doctor.
Medyo, di ba, financially constrained.
Yes
Now,
po.
do you think a plain skull x-ray will be enough? Kasi just to assess the temporal bone involvement? Or you really have to do a CT scan for the patient, although wala siyang neurologic problem, di ba?
Although the patient did not present, Doctor, with neurologic symptoms, I think for this particular disease po, Doctor, a CT scan is still mandated po to rule out CNS involvement po. Especially, Doctor, in the skull bone that is involved with the patient, which is the temporal bone. According to my readings po, Doctor, this one is a high risk CNS skull lesion po, Doctora, and has a high propensity to develop CNS involvement and diabetes insipidus po, Doctora. So we need to rule out po those things po, Doctora, and based on that po, Doctor, I think a CT scan is mandated po.
Okay.
Is warranted.
Thank you, Kevin.
Thank you po, Doktora.
Hi, good evening, Dr. Kevin. Congratulations for your presentation. Medyo nabitin lang ako dun sa referral mo sa Hima Onco. And I think even at PEDIA. So I think you presented the ideal. And I'm concerned that our patient is a low socioeconomic status with his parents. So have you discussed this with the Hima Onco, or you're still waiting with their management pa? Ideally kasi with case report, it's not only since surgery tayo, surgical lang, tapos after that walang follow up. This one kasi masyadong rare. Maybe other specialty like pediatrics and even anesthesiologists and yung Hima-Onco would look at this one if you plan this to publish in the future. So maybe since third world country tayo, so aside from the ideal, what would be other alternative and cost-effective way of management and follow-up to this patient? Kanina nabanggit na nga CT scan, kung pwedeng X-ray lang. Other than that, can you comment on that?
At least based on my readings po, sir, if the lesion po involves high-risk CNS skull lesion po, sir, patient is advised for chemotherapy after the surgery po, sir. For this patient po, we need first to confirm the diagnosis of LCH po, sir, since it can mimic other diseases po, sir. No po, hence the requirement of our immunohistochemical markers po, sir. If proven, sir, as LCH po, sir, this patient is to be referred to a pediatric hematologist oncologist. And currently, sir, in our government institution naman po, there's one, sir. So probably, sir, we can set this consult po, sir. And hopefully, sir, hindi naman po ganun kalaki po expenses niya if he will undergo chemotherapy po, sir. Pero we need, sir, to have the markers po, sir, to strengthen our diagnosis po, sir, of LCH po with this patient, sir. So yun po yung I think, sir, na kailangan pong mauna. And then we will immediately refer this to our pediatric hematologist consultant, sir. Hematologist oncologist consultant in our institution po, sir.
Okay, thank you very much. No further question.
Thank you po, sir. Thank you po.
Thank you po, judges. So we'll be proceeding with the next case report.
Our next case report will be the calvarial tuberculosis presenting as a lytic lesion of the skull in a 15-year-old male, a case report by Dr. Rubilin Casal.
Good day. Today I will present calvarial tuberculosis presenting as a lytic lesion of the skull in a 15-year-old male, a case report. Here are my objectives. We have a 15-year-old male with no known premorbid condition presented with a chief complaint of seizure. History of present illness that started 4 months prior when the patient accidentally bumped his head, from which he sustained a soft tissue swelling on the forehead. No consult was done and no medications were taken. After a month, the patient noted a non-healing nodular wound on the area of the soft tissue swelling. He sought consult at a private clinic and was given unrecalled medication. However, there was progression in the size of the non-healing wound. 4 days prior to admission, the patient had an undocumented fever and an episode of generalized seizure lasting for less than 1 minute. He was brought to a private hospital where plain cranial CT scan was done, revealing soft tissue swelling at the frontal bone region with mottled osteolytic lesion extending to the frontal sinus, large part of the frontal lobe exhibiting homogeneous brain density. The midline structures were not displaced. The patient was admitted at a private institution where he was given medications. Due to financial constraint, the patient's relative opted transfer at our institution for further management. Past medical history is unremarkable. Family history, his father and grandmother both had tuberculosis. His father also had diabetes mellitus and died of kidney failure. Personal and social history were unremarkable. On physical examination, patient is awake, not in cardiorespiratory distress, and follows command. His weight is 31 kg, height is 157 cm. Patient is underweight with a BMI of 12.6 kg per meter square. Vital signs were as follows. Febrile episode was noted to have with a Tmax of 39.4 degrees Celsius. For the skin, head, and neck, the presence of a 5 by 4 and 2 by 3 cm ulcerating lesion with erythematous border and necrotic crusted tissues at the center with purulent discharge were noted at the frontal area. For neurologic examination, no motor or sensory deficit or no signs of meningeal irritation was noted. The rest of the physical examination were all unremarkable. Patient was admitted under pediatric service with a diagnosis of brain abscess secondary to frontal osteomyelitis, severe malnutrition, COVID suspect. During admission, patient was referred to section of neurosurgery and a repeat cranial CT scan was done with findings of faintly enhancing, soft tissue focus with peripheral enhancement with mass effect. Consideration include infectious or inflammatory process. Thus, our working diagnosis during that time was intracranial mass, bifrontal area, severe malnutrition, COVID suspect. Our surgical plan was craniotomy excision of bifrontal mass, which was scheduled last June 9, 2021. Coronal approach was done with proper and careful dissection of the skin and periosteum. Location and identification of defect were done prior to craniotomy. The removed skull was noted to have lytic portion. Intraoperatively, there was 15 by 20 cm yellowish intracranial mass with extension to the skin of the frontal area. The mass was meticulously excised. Tumor was noted to extend up to the frontal dura and even to the superior sagittal sinus was sliced by the mass. Periosteal grafting was done on the site of the dural defect and remaining frontal bone was placed back to the site. Closure layer by layer and local tissue rearrangement of scalp were done. The complete procedure was craniotomy, excision of bifrontal mass, ligation of the anterior third of the superior sagittal sinus, obliteration of the frontal sinus, onlay graft, drain insertion, local tissue rearrangement of scalp with intraoperative findings as previously described. The specimen was sent for histopathologic examination, which revealed chronic granulomatous inflammation with causation necrosis and Langhans-type multinucleated cells consistent with tuberculosis etiology. On follow-up after 1 week, the wounds were well coaptated and with good healing. There was no neurologic deficit and medications were well tolerated. Currently, he is on a 20th week of anti-TB medication with good compliance under the surveillance of the TB Direct Observed Therapy or TB DOTS in his locality. The patient is also gaining weight. Household members have also been screened for tuberculosis and none were found to be infected. Tuberculosis is a curable disease, yet it is identified as one of the top causes of mortality among all infectious diseases. In 2010, it accounts 5.1% of total deaths in the Philippines according to the Department of Health. Clinical manifestations of tuberculosis are classified into two types, the pulmonary TB and extrapulmonary TB, with the former being the more common. Extrapulmonary TB is rare. Sites would include the following. Skeletal tuberculosis usually involves the weight-bearing bones and less commonly involves the flat bones or the skull bone. Calvary tuberculosis is an uncommon manifestation of tuberculosis and occurs in only 1% of cases of skeletal tuberculosis. An article by San An et al. Reported less than 60 cases of Calvary tuberculosis in childhood. Calvary tuberculosis is a primary tubercular infection is indeed very rare. But why is Calvary tuberculosis rare? The most plausible explanation is the trace to the mechanism of spread of TB itself. Isolated Calvary tuberculosis is rare due to the paucity of lymphatics and little cancellous component in the calvareal bones, specifically the parietal and the frontal bone. Furthermore, association of Calvary tuberculosis with tuberculoma is rarer still, but there are reports documenting the spread of Calvary tuberculosis to meninges and parenchyma, leading to tuberculoma formation of respective structure. Another thing that we should note is that the dura mater is extremely resistant to Calvary tuberculosis. And cerebral tuberculosis occurs only in small number of patients with skull lesion. Rarer still is the presentation of calvareo tuberculosis in our patient as a lytic lesion. Some of the more frequent calvareo lesion with lytic or mixed lytic or sclerotic appearance would include hemangiomas, epidermoid or dermoid, leukemia or lymphoma, Paget's disease, metastasis or eosinophilic granuloma, and calvareo tuberculosis is not a common differential. The treatment for this patient would include compliance to the regimen 2 TB medication, which comprise of 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 10 months of treatment of isoniazid and rifampicin. Once the TB regimen is completed and there are no signs of recurrence, frontal bone reconstruction can and will be performed. The patient and his relative were concerned of the possible cause of the procedure, but were advised a different channel of financial support. Close follow-up at our outpatient department at least twice a month was emphasized, to which they agreed with, to comply with. Thorough history and good clinical eyes were the initial keys in managing a patient. Managing the patient as a team with collaboration with other services like the Department of Radiology, Pathology, Internal Medicine, Neurology, Pediatric Neurology, nutrition support team, and TB adults can ensure appropriate and holistic management of our patient. Though these cases are exception to the run-of-the-mill patient, we should always be open to other possible rare cases that are just in front of us. Having a breadth of knowledge about disease entities can help us save more lives in the future. Here are my references. Thank you for listening. Good day.
Thank you, Doktora. Doktora, kaso pwedeng makiki-on lang yung camera, Doc?
Yes po, sir. Good evening po.
Good evening. Sige. So, dear judges, we have approximately 3 minutes each for the Q&A portion, Doc. So, si Doktora.
Hello. Ruby? Ruby?
Ayan po, nandiyan na siya.
Yes.
Sige po, Doktora Fuentes.
Okay, ako naman mauna.
Yes
Now,
po.
comment naman din. Regarding, kasi diba, this is a surgical, tawag dito, research case presentation. So, with regards to history, medyo dapat we are consistent with yung ano niya parang time niya. So, kung 4 months prior to admission, 4 months prior to consult, yung the following niya, because you wrote it down not 1 month after, parang dapat 3 months before admission or parang consistent siya, 3 months, 2 months before admission, to ganyan. And then, since it's a possible neuro case, it is but proper for you to note of the GCS, dun sa examination, di ba? Stable vital signs, GCS 15 ba siya or GCS whatsoever, no? And then, when you kasi you wrote there, they did a coronal approach. Majority of the readers, if it's interesting case, hindi naman lahat is a neurosurgeon or something. So this is a rare case, so dapat na-explain on how you conduct the procedure. Nakita mo ang dami mong parang may flap, may ganun. And it was not mentioned yung surgical parang technique or definition. Kasi if I will be doing, parang may case ako na ganun, at least I have an idea on how to go about yung procedure. And then also congratulations because you wrote there na parang yung duration of OT, blood loss, which is parang a good practice when we do yung reporting ng ating surgery. Now, my question is, why did you do a repeat scan? Will it change the management of the patient? Kasi previously meron na siyang CT scan, diba? Parang short lang yung interval, nagpa-repeat CT. Did the patient deteriorate or something?
So we did a repeat scan. Priorly po kasi the scan was done from outside other hospital, which is just a plain cranial CT scan. And there is still the persistence of the symptoms of the patient. So we did a repeat CT scan. And the repeat, we noted that there were change in the mass effect of the lesion or the mass to the brain tumor.
But
that's what we did for the surgery tumor.
Okay, but did it change the management? will it change? Kasi 'di ba, when we see patient, lahat ng financial nila, we have to consider. Now, if nakita nyo na may mass effect siya, the procedure, meron ka na agad idea on what neurological surgery yung gagawin mo. But kung may nadagdag lang, walang significant, yun nga, kaya tanong ko, baka nag-deteriorate yung patient, kaya medyo chinek ulit. Kasi CT scan is expensive.
Yes, ma'am. The prior CT scan po is, there is noted no mass effect on the prior CT scan. On the repeat po, there were the mass effect. That's why we opted for the surgery po.
Last question. How did you prepare the patient for surgery?
So first we did the laboratories, and we got the clearance from the pediatric surgery, pediatric department too, ma'am. And then when they re-stratified the patient, we opted for the surgery po.
Thank you.
Hi, good evening. Congratulations, Dr. Belin. Although here in the Philippines, common pa din ang ating tuberculosis. Most of our patients sa orthopedic, ito lang is masyadong rare siya kasi sa frontal bone. Okay. So I'm just concerned preoperatively. Would you do other diagnostic tests pa na we're thinking tuberculosis? Tapos another thing, is there an option for non-surgical procedures with this one?
Good evening po, sir. So for this patient po, sir, because it is the patient is presenting with neurologic symptoms, that's why we opted for the surgery po. And prior po kasi he was not diagnosed with TB, only on the histologic or the specimen po of the patient after the OR po, sir. Doon po na-diagnose po yung patient for TB, and nag-start din po agad ng medication for the patient po, sir.
Anyway, I encountered similar, although sa bone naman, since nagkaroon na tayo ng, before pandemic, we have this gene expert. Sometimes nadadiagnose na siyang TB. And I agree, this one, since symptomatic, I think the operation did well to the patient. Thank you very much. That's all.
Thank you, sir.
Sir Wesley,
Hi.
Yes, sir. Okay, thank you,
Hi.
sir.
Good evening, Dr. Acasao.
Good evening, sir.
So thank you for your presentation, and kudos on the documentation. No? Daming pictures, tsaka klaro. Anyway, my question is, at the back of your mind, did you entertain a one-stage procedure from the start, or was there an option to do a two-stage procedure, given that the area of concern is possibly infected, no, with the TB? One stage lang ba talaga yung option ninyo doing the reconstruction, or was there also a plan to do a two-stage? Let's say linis mo na ngayon, and then do a definitive reconstruction later on.
Good evening, sir. So the plan po for the patient po is the two-stage approach po, sir. So we explained to the relative that we would excise the mass po, and we will look for the extent po of the mass. So upon the histopath nga po, it is tuberculosis in etiology. So the management will be medical na po. And then we will reevaluate the patient after the treatment of anti-TB po, sir.
Yeah, pero this is a one-stage procedure lang, no? This was done in one setting, tama ba? Yung excision and reconstruction, this was done in one setting.
Reconstruction will be done later on po with the frontal bone reconstruction po. Future plan po for the patient po, sir.
So wala pang reconstruction dito. Okay, sige. Thanks for clarifying.
Thank you, sir.
Okay, yun lang. Thank you.
Thank you, Sir Wesley. Thank you, Dr. Akasaw. So we'll be proceeding with our next case.
Our next case will be a laparoscopic cystectomy with omentopexy for recurrent non-parasitic hepatic cyst. Case report and literature review by Dr. Carmen Arguello.
Good afternoon, doctors. I will be discussing a case of recurrent hepatic cyst. This is entitled Welcome Back Cyst. Patient is AC, a 27-year-old female who came in due to a chief complaint of abdominal enlargement. 8 months prior to admission, she noted a gradual abdominal enlargement, and consult was done in another institution where CT scan and ultrasound were requested, revealing a large hepatic cyst. She was then advised surgery. At 4 to 5 months prior to admission, she noted persistence of symptoms along with jaundice, ictericia, and tea-colored urine. She was admitted, and laparoscopic marsupialization of the hepatic cyst was done. This was done in another institution. Intraoperative findings include a cystic mass with thick walls and measuring approximately 12 by 8 cm inferior to the liver with 4 liters of serous fluid. The patient was discharged stable with gradual decrease of jaundice. 1 month prior to admission, the patient noted recurrence of symptoms including abdominal enlargement, jaundice, and ictericia. Tea-colored urine was also noted, and she was advised admission. Past medical history is unremarkable. Family history is also unremarkable, as well as the social history. Review of systems was also unremarkable. On physical examination, the vital signs of the patient was stable. She had jaundice, as well as ictericia, and on the abdomen, her abdomen was distended with normal active bowel sounds, and there was noted slight tenderness on the right upper quadrant and epigastric areas. Our working impression at this time is a recurrent hepatic cyst, post-laparoscopic marsupialization of the hepatic cyst. On admission, the patient had abdominal discomfort due to the enlargement. No nausea and vomiting was noted. She had flatus and BM, or bowel movement. Vital signs were stable. She was jaundiced with ictericia. Abdomen was distended with normal active bowel sounds, mild tenderness on the right upper quadrant and epigastric areas. These were the laboratories requested, and bilirubins and the liver function test, as well as the alkaline phosphatase, were all elevated. Imagings were also requested during her admission. Triphasic CT scan of the whole abdomen was done, revealing a well-defined and septated cystic mass measuring 20 by 18 by 13 cm in the right and left hepatic lobes. MRCP was also requested during this admission, and it revealed that the hepatic cyst had no connection with the biliary tracts. On the 7th to 8th hospital day, the patient had episodes of difficulty breathing and desaturations. Abdominal discomfort was also noted. Vital signs were unstable with a heart rate of 109 beats per minute, RR of 22, and O2 sat reaching up to 93%. She still had the jaundice. She had decreased breath sounds on the right lung filled with crackles, and her abdomen was still distended, still with the mild tenderness on the right upper quadrant and epigastric areas. This was a chest x-ray revealing the haziness in the right chest obscuring the lung, hemidiaphragm, and pleural space. The cause of her respiratory symptoms was believed to be from the compression of the large hepatic cyst, so she was referred to interventional radiology for percutaneous aspiration of the hepatic cyst. They were able to drain 2.2 liters of green fluid. After the percutaneous drainage, the patient was comfortable with no difficulty breathing or desaturations. Vital signs were stable. She was still jaundiced and with ictericia, globular abdomen with less distension compared to prior to the drainage, and it was non-tender in palpation. Patient eventually underwent definitive procedure. She had laparoscopic cystectomy with omental buttress and GP drain insertion, revealing large hepatic cyst of at least 20 cm in widest diameter at segments 4 to 5 with a fluid of 1,650 milliliters of green fluid. So in this image, you can see the gallbladder was pushed laterally by the cyst here, and inside the cyst cavity, you have the green fluid. Day 1 post-op, the patient was comfortable and not in pain. She had no subjective complaints. Vital signs were stable. Abdomen was soft and non-tender on palpation. The rest of the hospital stay of the patient was unremarkable. Histopathology revealed a fibrocollagenous tissue with old and new hemorrhage fibrosis. Final diagnosis is a recurrent hepatic cyst, status post-laparoscopic marsupialization of hepatic cyst, status post-laparoscopic cystectomy with omental buttress. Discussion. So for hepatic cyst, there are non-parasitic hepatic cysts which affect 5 to 10% of the population. Simple cysts are the most common benign lesions in the liver. They are congenital in origin and may arise from the aberrant bile ducts, which are obstructed from the main biliary system. Walls are made up of a single layer of cuboidal or columnar cells. There is also the polycystic liver disease, which is a cystic disease of the liver that contains 20 or more cysts present. Biliary cystadenoma is a slow-growing benign cystic lesion of the liver which may undergo malignant transformation. It originates in the bile ducts and composes less than 5% of cystic lesions in the liver. Cystadenocarcinoma is the malignant transformation of cystadenoma, again originating from the biliary epithelium. Hydatid cyst is caused by the tapeworm Echinococcus granulosus in its larval or cyst stage. Cyst growth in the liver is very slow, at least 1 to 5 millimeters in diameter per year. It is characterized by a spherical, fluid-filled vesicle with an intercellular layer and an outer laminated layer. So for the management for cystadenoma and cystadenocarcinoma, hepatic resection is the management of choice. For hydatid cysts, we can go for laparoscopic or open surgery. There is an option of percutaneous treatment by puncture aspiration, injection, and reaspiration method. There is complete cystectomy as a choice. Formal hepatic resection may be done if cystectomy is not possible. The important thing here is that you avoid rupture of the cyst. For the recurrence of the hepatic cyst, factors contributing to recurrence include inadequate deroofing or fenestration, deroofing of the cysts where adhesion formation encourages the recurrence, or the location of the cyst, especially if it is deep-seated or in the posterior segments of the liver near the diaphragm. Radical approaches include cyst excision, atypical resection, and lobectomy, and may induce a zero recurrence rate, but they have a higher morbidity, and thus they are not appropriate as a primary management. So recurrence rate of hepatic cyst after laparoscopic fenestration varies greatly from 0 to 25%. Techniques may include fulguration of the cyst bed, transposition of the omentum to the cyst bed, as was done with our patient, and ablation of the cyst wall with argon. However, there is little evidence supporting their efficacies. Omentopexy is proposed for cysts with exposed wall located intrahepatically or posteriorly at segments 7 to 8, or when the cyst size is greater than 10 cm, or when only 50% of the wall can be resected. Recurrence rates after the omentopexy is said to be reduced compared to simple laparoscopic deroofing. Some studies claim a 0% recurrence rate, however, more evidence is needed to support this claim. Efficacy of omentopexy is similar to laparoscopic deroofing during initial management of hepatic cysts. These are my references. Thank you very much.
Thank you, Doctora. So again, for our dear judges, we have 3 minutes each for the Q&A part. We may now ask Dr. Arguelles.
Hi, good evening. Ako muna.
Sir Mike.
Dr. Corbin, congrats for your presentation. And I just wondered if you did an effort to collaborate with the, you said that the first operation was done on other institutions because as a minimally invasive surgeon also, this thing could happen to me also. So I'm interested on the first operation, and you said the technique in marsupialization to decrease the the recurrence. So maybe an effort to see the first operation would enlighten us what need to be further done, or should be in mind for us for this recurrence not to happen.
Good afternoon. Good evening po, Doctor. I was able to retrieve the operative technique and the abstract, and that's where I based all the information from. As far as the operative technique was concerned, all they did was remove the cyst wall or the laparoscopic deroofing, but they did not put an omentum or omental buttress or an omentopexy, which is what was different in our in her second operation. Yun po.
And later on, how will you follow up this patient?
We will follow up this patient after 3 months to see if there's any recurrence of symptoms. Actually, in this patient, almost within that time frame, she started to develop again the abdominal enlargement and eventually jaundice. And the abdominal enlargement was already causing a mass effect. Wherein it caused the jaundice because there was constriction of the bile ducts due to the enlargement, and also as we can see, she started to have difficulty of breathing due to the mass effect. So that's one thing we can watch out for. Yun po, Doc.
Okay, thank you very much. No further question.
Thank you po.
Good evening, Dr. Argilies.
Good evening
Thank
po.
you. Hi, thank you for your presentation. I have 2 questions. First question, what's the possibility of a second recurrence in this patient? What's the possibility of a second recurrence? Kasi yung first was a deroofing, right? And then right now, ang difference was you did an omental buttressing. So is there a possibility of another recurrence in this case?
Yes po, Doctor, because even on researches po, Doctor, there is actually not much cases reported, not enough research done on recurrence of hepatic cyst. Most of the researches done are just about large hepatic cyst where they are treated either by sclerotherapy or laparoscopic deroofing, and they would utilize different techniques such as here omentopexy. Sometimes they would do ablation or cauterization of the cyst bed. But all the reports, whenever they report a recurrence, it would vary. Some would say the cyst would recur a second time, also with a recurrence rate of around 0 to 18%. So there's always a chance for recurrence. There's still not enough. Actually, that's what makes this case kind of interesting, because not enough research has been done on the proper management or the proper management of another recurrent hepatic cyst po. It's always just the primary hepatic cyst, and then it would suddenly recur after a few months.
Okay, thank you. Second question, Doctora. Would a cyst enterostomy have been an option? And what would have been the advantages if so?
For this patient po, Doctor, I don't think a cystenteroscopy would be done because sorry, because the cyst wall in this case is, I think it's too thin. Unlike in a let's say unlike a pancreatic pseudocyst, where the cyst wall is a lot thicker, we wait for the cyst wall to mature, and that's when you can do an enterostomy there. But in this case, the cyst is a lot thinner than a pseudocyst po.
Okay, thank you.
Okay. Hi, Carmen. Question. Why did you place a JP drain? What is it for?
Um, JP drain. Okay. The JP drain was just for for ano ito? Just to check if there are any if there's another immediate flow of cyst content after the omental buttress, because as I said, the cause of as according to research, the cause of a simple hepatic cyst it's usually from an aberrant bile duct. So that's one way to check if there's another immediate flow of the of the aberrant bile duct, and
But
if
you
there's
already did an MRCP, right?
yes, there's an MRCP. It's the MRCP confirmed that there was no connection to the major bile ducts. Yun po. This one,
So,
a simple hepatic cyst is more.
yes.
Yes, more on the aberrant bile ducts po ang simple hepatic cyst po, doctor.
Mhm. Kasi 'di ba anything that we place on a patient like a JP drain, NGT or Folicat may ano siya corresponding parang morbidity sa pasyente or pwede pa siyang magkaroon ng problem. Now kasi kung ano yung it should be stated kung anong purpose ng drain ha. Kasi if you say na parang to check if there's recurrence, do you think it will tell you kasi 'di ba binatres mo nga yun eh. So it will not help to determine early recurrence, I think, in my opinion. No, so siguro may ibang reason bakit siya nilagay doon. And then, it was said that you sent the specimen, yung fluid for analysis.
The cyst wall po. That's the histopathology report po.
Para kasi meron doon na fluid analysis was sent.
From the interventional radio when they aspirated the.
Was it requested by the surgery service or i-send lang ng ano ng
it was done interventional radio po. Interventional radiologist po.
Okay. Kasi I just want to know what's the reason for sending the yung ano na fluid for analysis. Definitely siguro kasi 'di ba it's a bile or something. Okay, thank you, Carmen.
Thank you, Dr. Carmen. Okay. So we'll be proceeding to our next case.
Our next case is a mistaken identity, a case of appendiceal mucinous neoplasm presenting as ovarian new growth, to be presented by Dr. Joan Celestine Trajano.
Good day, I am Joan Celestine Trajano and I am here to present an interesting case entitled Mistaken Identity, a case of appendiceal mucinous neoplasm presenting as ovarian new growth. To start off, appendiceal neoplasms are rare tumors accounting for less than 1% of all cancers and are usually discovered by chance during appendectomy. More than half of these tumors are symptomatic and are discovered incidentally, hence represents as one of the most enigmatic areas in the field of surgery. In women, appendiceal neoplasms usually present as ovarian tumors and are diagnosed in their advanced stages with extension to adjacent organs. Presenting a case of patient AO, a 42 years old female with the chief complaint of abdominal pain. So history of present illness revealed a 2-month history of enlarging abdomen with no other associated symptoms. 1 week prior to consult, the patient experienced intermittent left flank pain with no other associated symptoms such as fever, dysuria, hematuria, vomiting, or anorexia. Persistence of left flank pain, now associated with sudden and progressive right lower quadrant pain, prickling in sensation and character, and aggravated by movement, prompted consult. For the past medical history of the patient, no known comorbidities were noted. The patient underwent open cholecystectomy last 2008 and repair of incisional hernia last 2009. For the family and personal and social history, these were all unremarkable. For the OBGYN history, the patient is a known PCOS and underwent cesarean section for CPD last 2007. The review of systems of the patient was unremarkable. Vital signs of the patient upon consult were stable. Focus exam revealed a globular abdomen with normoactive bowel sounds and direct tenderness on the right lower quadrant and hypogastric area, with no palpable mass noted. Digital rectal exam of the patient revealed no palpable intra or extraluminal mass, intact rectal vault with no blood per examining finger. Diagnostics of the patient of CBC and electrolytes were all normal. Transvaginal ultrasound was requested, revealing a normal uterus and left ovary, a non-visualized right ovary, a heterogeneous pelvo-abdominal mass measuring 19 by 10 by 14 cm was noted, with irregular border containing mixed cycles. This was probably gastrointestinal in origin, however cannot totally rule out ovarian new growth. Presence of free fluid in posterior cul-de-sac was also noted. Abdominal pelvic mass measuring 12.9 by 19.8 by 19.2 cm with enhancing walls and internal septations. Fluid accumulation was seen in perihepatic, perisplenic, and both paracolic gutters and pelvic regions. The liver was noted to have two hypodense foci on the left hepatic lobe. Intestinal pattern was non-obstructive and the appendix was not confidently visualized. At this time, the impression was torsion versus ruptured left adnexal mass. The patient was then advised surgery and underwent exploratory laparotomy. The interoperative findings were noted a large complex mass measuring 19 by 14 cm coming from the left adnexa with mucinous content and point of rupture at the superior area, probably resulting to an intra-abdominal spread of the mucinous material. Mucinous ascites and adhesions of the small bowels to the mass and posterior uterus were also noted. The appendix was edematous, with its swollen tip covered in mucinous material. The rest of the intra-abdominal organs were unremarkable. Shown in this picture is the left ovarian mass with the point of rupture at the superior area. This was the left ovarian mass. This was the uterus with note of normal cervix and right fallopian tube as well as normal ovary. And this was the appendix. The final histopathological result revealed a ruptured low-grade appendicial neoplasm with a tumor size of 4 centimeters. The tumor involved the left ovary and a cellular mucin noted on the omentum, peritoneal fluid, and left peritubral tissue. For our discussion, malignancies of the appendix are a rare group of tumors that are often found accidentally during surgical removal of the appendix. Histologically, this malignancy represents 0.5 to 1% of all biopsies after appendectomies. Low-grade appendiceal mucinous neoplasms are among the most uncommon appendiceal tumors, with an incidence of 0.7 to 1.7%. Incidence of this neoplasia is around 1 to 2 per million, with women over 40 years old being the most affected. Ovarian involvement in appendiceal mucinous neoplasms is widely documented, with ovarian metastasis discovered in 50% of appendiceal tumor patients. So patients with tumors of the appendix may present with non-specific clinical manifestations that delay diagnosis. So early presentation during the early stages of this disease presents with acute appendicitis with right lower quadrant pain and is the most clinical presentation, while in advanced stages, they manifest as an increase in abdominal girth due to the buildup of mucin in the peritoneum. Pseudomyxoma peritoneae is a clinical condition caused by the rupture of neoplastic mucinous lesions of the appendix, leading to progressive intraperitoneal dissemination and accumulation of both mucinous ascites and neoplastic cells. So PMP is very difficult to diagnose early and accurately, which frequently lead to clinically advanced stages at the time of their diagnosis. So in the differential diagnosis of a right-sided pelvic tumor, it is important to take note that all gynecologists or general surgeons should investigate appendiceal mucosine. CT scan is the most frequent imaging modality used to examine the primary tumor and assess for metastatic disease. A combination strategy of laparoscopy, cytoreductive surgery, and heated intraperitoneal chemotherapy is considered the standard treatment in patients with mucinous neoplasms and peritoneal spread of illness. For both diagnostic and therapeutic purposes, all appendiceal mucinous lesions should be removed. Even though the radiological impression is benign, surgery is nevertheless recommended since there are no solid criteria for excluding cancer. Ovarian involvement is common in women with peritoneal spread, as stated before, that hence bilateral salpingio-oophorectomy should be highly explored in women due to the potential of ovarian metastasis. In conclusion, appendiceal neoplasms are uncommon, with more than half of these patients being asymptomatic and a third of cases are already metastatic at the time of diagnosis, resulting in much poorer outcomes. It is therefore very essential to build a strong foundation of diagnosis and effective management for this kind of patients by developing heightened awareness and clinical suspicion, timely recognition, and early referral to a specialist center for further workup and management. Also, an interprofessional team comprising of surgeons, other involved specializations such as oncologists and radiologists must also be instituted in order for them to communicate effectively with one another to ensure reduced morbidity and mortality for patients presenting with appendiceal neoplasms. Thank you. Good day.
Thank you, Doctora. So again, our dear judges, 3 minutes each for the Q&A.
Hi, good evening, Dr. Joanne.
Evening, sir.
Hi, thank you for your presentation. Question, given that the histopather now to be appendiceal carcinoma, and looking at the pictures earlier, it looks locally advanced, no?
Yes, sir.
Is there any plan to do a second surgery? Is there any plan to do like a right hemicolectomy or a more radical procedure?
Actually, for now, sir, the current guidelines, the suggestion on the studies that I've read, they prefer what do you call this? Cytoreductive surgery and HIPEC or the intraperitoneal chemotherapy. So the patient is doing is currently ongoing her fifth cycle of chemotherapy, sir, of oxaliplatin and capecitabine po. So after that, what they plan is to reassess again the patient if the with regards to how well her tumors if they recurred or if they were already controlled.
Okay. Let's say in retrospect, no? In retrospect, had you known that this was let's say pseudomyxoma peritonei, would you have, and let's say everything is available, would you have done the HIPEC as you mentioned?
Yes, sir. If preoperatively, what do you call if preoperatively, pseudomyxoma peritonei is already um is suspected for the patient, the standard of treatment is already CRS and HIPEC. However, this wasn't applied in the case because the patient underwent immediate surgery and it was only later found out that it was already appendiceal in origin.
Okay. In your bibliography, it was mostly HIPEC, no, yung mga references mo.
Yes,
Are you familiar with PIPAC? Instead of HIPEC, PIPAC, PIPAC?
I haven't read about that.
Okay. Anyway, aside from HIPEC, meron rin kasi yung tinatawag na PIPAC. So I think in first world countries, they are doing it now. It's called pressurized intraperitoneal aerosol chemotherapy. So instead na liquid ibibigay nila, aerosolized. So yun. Siguro something nice to read about, no? Baka pwede pandagdag sa bibliography mo.
Yes, I would.
Yun lang. Thank you. Thank you.
Thank you, sir.
Hello, Joanne.
Yes, ma'am. Hello po.
Oho. Marami na itanong si Dr. Wesley kasi na specialty niya. Okay.
Sorry, Malu.
So, may wala akong tanong. So, ito lang yung question. Because your physical exam did not note of a palpable mass.
Yes,
Is the
ma'am.
patient morbidly obese or obese?
No, ma'am. The BMI of the patient is actually 27. But then upon physical exam, there was no note of palpable mass in the patient, despite the tumor being 19 centimeter.
Okay, so no palpable mass.
Yes, ma'am.
Okay, sige. Next question. How do you do surveillance on this patient since there are, medyo ruptured yung LMAN mo? So how do you do surveillance?
Okay, so for the surveillance of the patient, the recommended guidelines for those with peritoneal spread already of the mucin is CT scan 6 months, every 6 months for 2 years, ma'am. And then after that is yearly for the next 5 years.
How about tumor markers?
Tumor markers, ma'am, we can do the guide. They can do CA 125, CA, and then PET scan is also recommended for the patient to assess for other metastatic lesions in the body.
CA 19-9. Included siya dun sa another tumor marker. So this one was this tumor marker requested sa patient?
The patient was discharged 4 days after the operation, and then the patient underwent chemotherapy at another institution. So upon follow-up, the patient was requested CA 125, and then however she failed to mention the values because she was undergoing chemotherapy the last time I talked to her. And then I'm still following up with regards to the values of it, but it was elevated, hence they started her as well with the chemotherapy.
Okay. Thank you.
Thank you, ma'am.
Hey, good evening, Dr. Joanne. Congrats for your presentation. Anyway, I suppose this is a collaboration or team effort with the gynecologist. Una ko makita yung specimen, saka yung mga CT scans saka ultrasound. Iisipin ko parang gynec case siya eh. So, yeah. Inquire ko lang, sinong initially nag-open? Surgery or gyne po? Tapos, yes, oo. So kasi nabanggit mo kasi kanina na standard of care is laparoscopy. So if for example you chose that standard of care, diagnostic laparoscopy, would it change your management?
For the patient, no, because the tumor, as seen by the ultrasound that I've placed and the WABs and the whole abdominal CT scan, the mass was already big and the patient was already presenting with tenderness on the right lower quadrant. So upon talking to the patient during the time of admission, the OB/GYN doctors preferred already for the patient to undergo TABSO because they were initially thinking of ovarian new growth. That's why their advice is to undergo TABSO already for the patient because of the age as well.
Anyway, another thing, would you think during the procedure you do lymph node dissection?
We did omentectomy for the patient, but lymph node just omentectomy. And then appendectomy.
Okay, that's all.
Thank you, sir.
Thank you, judges. Thank you, Dr. Trajano. So we'll be proceeding to our next case.
Good day. I am John Celestine Trajano, and I'm here to present an
Our next case is a spontaneous splenic rupture on a pulmonary arteriovenous malformation patient to be presented by Dr. Kenneth Erson Lumban.
Good afternoon, everyone. I'm Dr. Kenneth Lumban, first-year surgery resident, and I'm here to present my case entitled A Series of Unfortunate Events. This is a case of patient AV, an 11-year-old female Catholic Filipino who currently resides in Binyan, Laguna. Patient presented with abdominal pain of 1 day duration. 1 day prior to consult, patient had sudden onset of epigastric pain with a pain score of 4/10. Associated symptoms include 2 episodes of vomiting, nausea, undocumented fever, and decreased appetite. Patient was given paracetamol, which provided relief. 4 hours prior to consult, abdominal pain persisted with migration of pain on right lower quadrant. Patient was brought for consult in a primary hospital where workup was done. Patient advised transfer of institution, hence consult at ER. The patient was previously diagnosed with PTB last 2015 and completed 6 months of treatment. Patient is also known case of pulmonary arteriovenous malformation since 2019. Patient has no history of trauma, accident, no previous surgeries, no known allergies. For review of systems, patient was reported to have recurrent epistaxis, shortness of breath which was related to exertion, clubbing of fingers for both upper and lower extremities, and circumoral cyanosis. For physical examination, patient is awake in pain in respiratory distress with the following vital signs. There is notable circumoral cyanosis and telangiectasias on oral cavity and bilateral buccal area. P of chest and lungs revealed crackles on mid to base of both lungs. P of abdomen revealed soft non-descended abdomen with normal active bowel sounds, non-palpable liver and spleen, with right lower quadrant tenderness during direct and rebound palpation. Key of extremities noted clubbing of fingers on both upper and lower extremities. DRE revealed unremarkable findings. At this point, our initial impression was acute abdomen probably secondary to ruptured appendicitis, PCAPC, pulmonary arteriovenous malformation, and COVID probable. Let's go to the course of events that happened to the patient. Baseline CBC showed normal hemoglobin but increased WBC at 18 with neutrophilic predominance of 0.83. Patient tested negative for pregnancy tests. At this point, the pulmonary CT scan was done, which revealed previously identified AV malformation. Full abdominal CT scan revealed normal size spleen, but surrounding the spleen are hyperdense materials conforming to the splenic margins. They are considering intrasplenic parenchymal hematoma with massive preperitoneal fluid, most likely hemoperitoneum. Patient became hemodynamically unstable. Abdominal exam revealed generalized abdominal tenderness. Repeat CBC revealed decrease of hemoglobin from 145 to 95. Patient was brought to OR and underwent emergency exam. Intraoperatively, approximately 750 cc of hemoperitoneum was noted and evacuated. 2 units of PAC-RBC was transfused intraoperatively. Blood clots were observed and localized on the splenic area. Grade 3 splenic injury was noted, with them proceeded with total splenectomy. Inspection of appendix revealed minimal suppuration on right lower quadrant, with them proceeded with appendectomy. Appendix appear to be normal looking grossly. The diaphragmatic surface of the spleen is smooth with no hematoma or laceration. Here's a visceral surface of the spleen. Take note that the inferior border of the spleen was severely damaged. Our post-operative diagnosis is the following. Post-operatively, repeat CBC after 2 units of PAC-RBC revealed an increase of hemoglobin from 95 to 130. At this point, the patient was diagnosed with hereditary hemorrhagic telangiectasias or HHT using the Carasol criteria. Criteria include the following. 3 out of 4 criteria is present in the patient, which makes her a definite case of HHT. The post-operative course was unremarkable. Vaccines are given as outpatient. Histopath of the appendix confirmed acute appendicitis. Histopathology of the spleen is described to have irregular defect on its inferior border. Microsection spleen are noted to have wide areas of necrosis, congestion, and hemorrhage. Let's discuss the case. The patient came in with known case of pulmonary AVM. It could be idiopathic or related to HHT. Estimated about 70% of the case of pulmonary AVM are associated with HHT. HHT is a vascular disorder closely related to visceral AV malformations, hepatic AVM being the most common and present in 70% of the case, followed by pulmonary AVM being the second most common. Our patient presented with intra-abdominal bleeding with significant hemorrhage related to the spleen. I found reports that documented the splenic involvement in HHT patients. The most common ones are splenic artery aneurysms, spleen telangiectasias, and spleen arteriovenous malformation. Our patients closely related to the rupture of spleen AVM. Here's a case report of an 11-year-old female with reports of recurrent epistaxis who came in due to abdominal pain. Imaging revealed pulmonary AVM and CT of spleen revealed multiple pancreatic calcifications consistent with arteriovenous malformation. It was identified that blunt abdominal trauma is the most common cause of splenic injury, and in some instances, spontaneous rupture can still happen. So in splenic ruptures, we ask the question if it is traumatic or spontaneous. Here's a criteria to diagnose spontaneous splenic rupture. Causes of spontaneous splenic rupture are as follows, neoplasm being the most common cause of spontaneous rupture. This is the grading of splenic injury. Our patient belongs to grade 3 splenic injury since there is involvement of the trabecular vessels. So what should we do with splenic injury? For grade 3 and higher, splenectomy is warranted. Partial splenectomy is recommended in pediatric population. However, in emergency cases, total splenectomy is done. Take note that if it is proven to be spontaneous, splenectomy is warranted. Let's talk about APSI or overwhelming post-splenectomy infection. Although rare, it is the most feared infectious complication of splenectomy. Vaccines such as pneumococcal, meningococcal, and Haemophilus vaccines are recommended to be given. In elective surgeries, vaccines are given 2 weeks prior to procedure. In emergency situations, vaccines are given 2 weeks post-operatively. In conclusion, pulmonary AVM patients should be screened for presence of hereditary hemorrhagic telangiectasia. HHT is an uncommon disease that is still remain underreported. Splenic involvement in HHT is relatively rare manifestation. Related guidelines for screening and management are still needed to be established. Splenectomy is warranted in cases of proven spontaneous rupture of spleen, and APSI is most feared complication of splenectomy, and vaccination against capsulated bacteria is recommended. Thank you for listening.
Okay, for the Q&A, judges, 3 minutes each.
Good evening, Kenneth. So, my question is, you already have a CT scan, right, prior to doing the surgery?
No, Doc. We did a CT scan because the patient presented with generous abdominal tenderness. Initially, we consider acute appendicitis, a ruptured one. And then when the patient presented with generous abdominal bleeding and decrease in hemoglobin, that's the time we consider doing the CT scan, Doc.
Okay, yes, but you did the CT scan prior to doing the surgery.
Yes,
Am I
Doc.
correct? Yes. So, ang comment lang, you wrote there, you did schedule the patient for exploratory laparotomy, correct?
Yes.
Kasi ito kung kunyari meron na tayong diagnostic and already meron na official result, it should be parang procedure directed already. Kasi you're highly considering that the patient has parang spontaneous splenic rupture, whatever, something to do with the injury dyan sa spleen mo kasi nandun yung hematoma. So it should be stated na laparotomy, splenectomy, ganyan na siya laparotomy, possible total splenectomy or whatsoever. Hindi explore kasi exploratory, wala ka pang idea kung ano yung makikita mo, so you're exploring. second question pala. Why did you do appendectomy?
For the appendectomy, we did appendectomy because of the clinically it is warranted, Doc. We have an increase of WBC, and then the presentation of the case is consistent with appendicitis.
But the CT scan results showed that
for the CT scan, it was the appendix was not identified, though. It was obscured.
Kasi 'di ba sabi mo the patient became unstable. That's why you decided to do a parang surgery, right?
Yes, Doc.
So kumbaga man sa dictum natin kasi fast in fast out kasi kung you consider the patient unstable. So we don't do parang appendectomy kasi hindi na aim ng pasok mo eh. Kaya nga yung medyo diagnostic mo will tell you on the procedure that you will do to the patient. Kasi kung kunyari biglang nag-table death yung patient, nag-appendectomy pa kayo. Alam mo yon? So dapat splenectomy kung okay kasi acute appendicitis kung may nakita kayong parang suppuration, kung wala naman siyang appendiculate, you may just give antibiotic kasi kung unstable yung patient. Okay.
Hi, good evening, Dr. Kenneth. Congrats to your presentation. I suppose that since you're preoperatively, you're considering pathologic spleen because of the AV malformation. In your conduct on your operation, other than the splenectomy, did something else aside from appendectomy and splenectomy?
In splenectomy, we did inserted GPD.
Okay.
And evacuation of hematoma.
Anyway, did you explore for possible ectopic spleen in the omentum or mesentery or other parts of the abdomen?
Yes, Doc. We didn't find any findings, any ectopic implantation of spleen tissues on other organs, Doc.
So I think you should note that also in your intra-op, because since this is a pathologic spleen, it could require. Okay. I think that's all.
Hi, good evening, Dr. Lumban.
Good evening, Doc.
Hi, so again, thank you for your presentation. First is a comment, the same with Dr. Marilu Fuentes, regarding the appendix. Kasi you mentioned the appendix look normal. You even showed the picture. Grossly, you mentioned that grossly it looks normal, no? So anyway, the same comment with Dr. Fuentes on that one. Question, pre-op, why did you decide to start the patient with pip/tazo plus amikacin? What was at the back of your mind then? Bakit bigla kagad na pip/tazo kagad? Why not, let's say, amoxiclav or let's say sifoxetine, yung mga less stronger medications?
Yes, Doc. Because for pip/tazo, because we are considering ruptured appendicitis, Doc. That's why we give pip/tazo, and also for the amikacin, it was given because the patient has we're considering pneumonia, Doc. So
Pneumonia.
that's why the pediatric service started amikacin.
Okay. Second question. What's the recorded incidence of patients dying before being operated on? This is good kasi at least ito nahabo na the patient, although there's a spontaneous rupture here, at least nahabol ninyo, di ba? So that's good. Pero what about in other cases? What's the incidence of patients dying before being operated on?
They just stated that the condition is related to high mortality.
So wala silang binigay na numbers?
Wala.
Wala, okay. Last question. In retrospect, What could have been the pathophysiology of the splenic rupture in this case?
Yes.
Kasi maraming
Because
theories, di ba?
yes,
Okay,
sir.
sige. Continue, Dr. Lu.
Sorry, sir. Since the patient has a autosomal dominant condition known as HHT, it is related to the formation of the vessels, doc, with the patient. So we're considering also HHT is related to different kinds of AV malformations in the body. It was stated earlier that aside from hepatic AVMs, it can be other AVMs can also manifest to the patient. So the concern there is the vessels involved in HHT patients, they have a high tendency to rupture.
Okay, that's all. Thank you.
Thank you, Doc.
Thank you.
Thank you, dear judges. Thank you, Dr. Lumban. Okay, so we'll be proceeding to our next case.
Our next case is a sebaceous carcinoma of the sinonasal orbital area, to be presented by Dr. Maricel Dalawampo.
Pleasant afternoon to everyone. Sebaceous carcinoma is a rare malignant neoplasm that is known to arise from adnexal epithelium of sebaceous glands. Sebaceous gland carcinoma commonly arises in the periauricular area and is an uncommon condition and represents 1 to 1.5% of eyelid malignancies and is considered to be the third most common eyelid malignancy after basal cell and squamous cell carcinoma. Today, I'll be presenting a case of a 56-year-old Filipino female who presented with a mesoorbital mass on the left. With a history of present illness which started 5 months prior to admission, she complained of a teary eye discharge associated with a sub-centimeter non-erythematous papule at the medial canthus of the left eye. No blurring of vision and limitation as eye movement. She consulted an ophthalmologist and was prescribed with an ophthalmic drops which afforded temporary relief. 4 months prior, there was gradual enlargement of the mass, now with extension up to the left nasal area. She then again sought consult where she was prescribed with antibiotics, which she took for 1 week. 1 month prior to admission, the mass noted to be erythematous hard with slight tenderness associated with difficulty in opening of the left eye. Patient sought consult and underwent incisional biopsy of the mass, which turned out to be positive for sebaceous carcinoma. She was then advised for definitive surgery. The histology of the mesoorbital mass stained with hematoxylin eosin showed sheets and lobes of tumor cells separated by fibrovascular stroma. There is increased proportion of the mature appearing pseudocytes, and there is mild to moderate pleomorphism, mitosis, and necrosis. So for the salient picture of a 56-year-old Filipino female, came in with a chief complaint of a mass on the left mesoorbital area associated with limitation of eye opening with horizontal globe dystopia, no palpable cervical nodes with no known comorbids, unremarkable family history, no history of exposure to radiations, no family history of cancer, underwent incisional biopsy which turned out to be sebaceous carcinoma. The diagnosis is mesoorbital sebaceous carcinoma on the left, status post-incision biopsy. The orbital scan with contrast showed an irregularly bordered homogeneous soft tissue mass defect, primarily occupying the left ethmoid sinuses, extending through the left medial wall of the left orbital cavity, spacing the orbital globe laterally to the left, measuring approximately 3.3 by 4.6 by 4.4 centimeters, which enhances homogeneously after contrast administration and shows no calcifications. Encircled in red is the mass and its relational invasion to nearby structures. Wide excision of the mass with a 5 mm margin, medial maxillectomy and orbital excentrivation left with frozen section was performed under general anesthesia. Shown here is the post-operative image of the patient showing the defect after the wide excision, side by side with a specimen which was sent for frozen section. A large defect was noted after the wide excision with exenteration, and the defect was filled with wet gauze with a dry top dressing and will be allowed to heal by secondary intention. The gross specimen of the mass, including the eyeball left with borders as labeled. The frozen section report is compatible with sebaceous carcinoma left nasoorbital mass, 4.2 cm in greatest dimension. The following surgical margins are negative for tumor: 2 mm medial, greater than 5 mm lateral, 3 mm superior, and greater than 5 mm inferior, and base of the eyeball. However, the deep and basal margin are both positive for tumor during the frozen section report. Additional margins sent for final histopathology reading that turned out to be positive for malignancy include the median maxillary wall, frontal sinus, superior orbital, frontal sinus mucosa, frontal sinus anterior table left, frontal sinus interseptal wall, superior turbinate intraorbital nerve, and the septum. So microscopic examination showed a malignant tumor composed of sheaths and lobules of epithelial cells with moderate sebaceous differentiation. There is moderate to marked pleomorphism, mitosis, and necrosis. So for the final diagnosis, it's sino-nasoorbital sebaceous carcinoma stage 3, E3N0M0 status post-incision biopsy, October 11, 2020. Sebaceous carcinoma is a rare but aggressive malignancy with a 5-year overall survival rate of 78% for localized or regional disease and 50% for metastatic disease. This neoplasm has non-specific clinical presentations, allowing it to mimic benign inflammatory conditions such as follows. Majority of the sebaceous carcinomas arise spontaneously and de novo. 75% of cases arise in the ocular and neck, while 25% arise from an extraocular lesion. The incidence of sebaceous carcinoma is 0.5 per million in the population older than 20 years old in the US. And the mean age of diagnosis has ranged from 57 years to 72 years old. Approximately 70% of sebaceous carcinoma occur in the females. Known risk factors include immunosuppression, ultraviolet exposure, and radiotherapy. Sebaceous carcinoma tend to metastasize to regional parotid, submandibular, preauricular, and cervical lymph nodes. There are also reports of periauricular sebaceous carcinoma with distant metastasis to the lung, the bone, the liver, and brain, with mortality rate as high as 30%. A high index of suspicion is warranted in patients who present with recurrent or treatment-resistant lesion, blepharoconjunctivitis, or keratoconjunctivitis. The diagnosis is made histopathologically. Treatment is usually chosen on the basis of the extent of the tumor and the specific needs of the patient. Surgical excision remains the mainstay of treatment for sebaceous carcinoma, and most authors advocate a 5 to 6 mm margin of normal appearing tissue. In cases of microscopic and subclinical diseases or positive surgical margins after surgery, like in the case presented, radiation therapy can be advocated, although the optimal radiation dose is still unclear. Adequate disease control must be achieved by combined modality approach of radical surgery followed by post-operative radiation therapy. The clinical presentation is non-specific, and definitive diagnosis of this tumor relies on histopathologic confirmation, which can be challenging. The existing literature related to the treatment of sebaceous carcinoma primarily consists of small to medium-sized case series and isolated case reports, impending the possibility to reach a clinical consensus. Thank you. So in conclusion, delayed diagnosis and inappropriate treatment coupled with the inherent aggressive behavior of the tumor result in an unacceptably high incidence of local recurrence, regional lymph node metastasis, systemic metastasis, and even death.
Unfortunately, Dr. Delon is on emergency leave. So may I ask our dear judges instead if they have any comments or take-home points for our residents and students who are watching regarding the case. Thank you.
Anyway, good evening to congratulate also Dr. Maricel. Anyway, this is actually a multidisciplinary case, an effort to, I don't know if only the surgery or the head and neck or the ENT uh, did it. I believe pre-operatively, it is also referred to oncologists and with the incision biopsy they have. And I think my concern is that is there an effort to downgrade the tumor? And then another thing, is there a need for neck dissection or lymph node biopsy? That's all.
I agree with Doc Mike regarding dun sa MDTC kasi medyo morbid yung surgery, no? So, medyo dapat na plan siya na parang one, kung maa-achieve ba na magne-negative margin or R0 surgery. Kasi even if we remove the tumor, yung bang quality of life ng patient, was it improved? Or parang medyo magkaroon pa siya ng psychological problem because there was orbital exenteration, right? So, kung may role ba ang neoadjuvant, kung sakali, kung mas shrink siya, mas less yung parang aggressive procedure for the patient. Yun lang din.
Hi, good evening. Well, first of all, ang comment ko, congratulations to Dr. Dalawampu on her, actually her abstract was well written. Tsaka kudos to her for the documentation. Okay naman, maganda naman yung mga pictures na nakuha, no? So, well documented naman. Other comments regarding sa case, I agree with the rest of our judges, no, regarding dun sa pagiging complex nung case. I agree with the MDT. At saka yung commentary ni Dr. Fuentes na, well, I don't know if neoadjuvant would have been an option also in this case. Kasi if you review the case, ang histopath was positive yung margins, no? Positive yung margins nung patient. So, what's in it for the patient post-op? Are there any plans to do adjuvant therapy, like adjuvant chemo ba or adjuvant radiation? Meron bang role? And another question that came to mind was, kasi sabi is there's a propensity to metastasize to regional nodes. Was the next scan pre-op? No? So, well, yun yung some of my questions. And kumusta ang patient now with regards to the quality of life, no? Kumusta siya during follow-up? Anyway, those are some of the comments and questions in mind. Thank you.
Thank you very much to our panel of judges. At this point, we will be computing for our scores. So while we wait, I think our sponsor has a few words and a product presentation. Thank you.
The new normal is just a new phase in this walk of life. Like all of life's phases, it is best embraced and faced head-on. Life is precious and even more beautiful. Cathay Drug's mission to deliver quality medicines that are within reach of every average working Filipino continues and intensifies. With you as our valued partners, we will continue to provide quality healthcare solutions for every Filipino household. Anti-infectives, Bactiv, Monowell, Protozol, Widox, and Silverderma. Anti-neoplastic agent, Kalubia, Alpha-1 adrenoceptor blocker, Tanzor, anti-osteoporosis, Bondros, non-steroidal anti-inflammatory, Coccidia. Your partner in facing life's health challenges. Cathay Drug Company Incorporated. Here for you every step of the way.
When it comes to treating bacterial infections, you gotta know what you're up against. Because sometimes, it only takes one if done really well. Monowell. Monowell is a broad-spectrum bactericidal antibiotic indicated for the treatment of infections caused by susceptible strains of gram-positive and gram-negative pathogens, both aerobic and anaerobic. The unique molecular structure of Monowell gives a particularly high degree of resistance to beta-lactamases, a major mechanism of bacterial resistance to penicillins and cephalosporins. Monowell is indicated for the treatment of gynecological infections, septicemia, endocarditis, respiratory tract infections, bone and joint infections, and skin and soft tissue infections. It is also indicated for the prevention of post-operative infections in patients undergoing surgical procedures. The power of one. Get the strength and reliability with monotherapy with Monowell.
Fighting strong, without hesitations. Confidently, defeating the enemy. Actively combating infections head-on with Bactiv. Bactiv is an antibacterial combination of amoxicillin and the beta-lactamase inhibitor clavulanic acid. This association makes Bactiv an antibiotic agent with a broad spectrum of activity against a wide range of bacterial pathogens. Bactiv is indicated for short-term treatment of upper and lower respiratory tract infections, genitourinary tract, and abdominal infections, and skin and soft tissue infections. Bactiv is available in 625 milligram film-coated tablets, 1 gram film-coated tablet, 500, 100 milligram powder for injection, and 1 gram 200 milligram powder for injection. Achieve victory in the combat against bacterial infections with Bactiv.
You're not you when you're in pain. Don't let it take you over. Coax the pain out with Coccidia. Coccidia is a non-steroidal anti-inflammatory drug used in the treatment of rheumatoid arthritis, osteoarthritis, ankylosing spondylitis. It is also indicated for the management of acute pain and dysmenorrhea. Coccidia is also used as an adjunct therapy to reduce the number of adenomatous colorectal polyps in patients with familial adenomatous polyposis. Coccidia is available in 200 mg and 400 mg capsule. When in pain, take Coccidia. It's programmed to take over pain. it's not flowing as it should because of BPH? Let it stream naturally. Releasing is easy with Tamzor. Tamsulosin hydrochloride, Tamzor, is an alpha-1 adrenoceptor blocking agent indicated for obstructive symptoms in men with benign prostatic hyperplasia, BPH. It works by releasing smooth muscles in the prostate and bladder, which helps improve urine flow and reduces symptoms of BPH. Tamzor 400 mcg prolonged release capsule is recommended to be taken once daily for the treatment of the signs and symptoms of BPH. Let it flow with ease with Tamzor.
Thank you, Tatay Drug, for sponsoring this event. So hopefully we'll see you on the next episode ng ating annual research contest next week. So let's welcome back Dr. Mike Lawenko for the presentation of the certificate of appreciation to our judges.
Yes, okay. So, thank you, dear judges, for gracing this event. So, a certificate of appreciation is given to Michael Dennis de la Paz in his capacity as one of the judges during the PCS PSGS Southern Tagalog Chapter Annual Research Contest Interesting Case category, given this 9th day of November 2021 via Zoom. Signed by Dr. Arvin Briones as the president of PCS STC and myself as PSGS STC. So thank you, Dr. De La Paz.
Thank you also.
Next will be a certificate of appreciation given to Marilu Fuentes in her capacity as one of the judges during the PCS PSGS STC Annual Research Contest, the Interesting Case category. Again, signed by Dr. Arvin Briones and myself. Thank you, Marilu.
Thanks, Boss Mike.
And of course, a certificate of appreciation is also given to Dr. Wesley Reyes in his capacity as one of the judges during the PCS PSGS Southern Tagalog Chapter Annual Research Contest Interesting Case category. Given this 9th day of November 2021, signed by Dr. Arvin Briones as president of PCS STC and myself as PSGS STC. Bye, salamat. Congrats.
Thank you, Mr. President. Thank you, Southern Tagalog Chapter.
Thank you, dear judges. Maraming salamat po sa inyong presence at saka inputs po dito sa event. Sobrang laking bagay po para sa atin lahat and marami po kami natutunan. Kahit po yung mga nanonood lang, marami pa rin natutunan mo talaga. So, while waiting for the results ng ating committee na research committee, will be presenting some videos. Mostly nakita na natin yung iba, pero yung mostly mga videos to na ginawa during the last year ng mga for Christmas at saka sa Foundation Day. So, okay. Wait lang po. course nga pala po, if habang naghihintay tayo ng result po ng contest, if gusto niyo po mag-dinner muna, have a quick break, coffee break, beer break, water break, pwede niyo muna pong gawin ngayon and balik po tayo kaagad. Hopefully sa susunod na taon, face-to-face na tayo. So sabay-sabay tayong kakain muna ng lunch habang naghihintay ng result ng evaluation. So again, thank you sa Katay Drug sa sponsorship ng event. Thank you sa judges. Thank you po. Thank you po. Thank you very much.
There's a place in your heart, and I know that it is love. And this place is much brighter than tomorrow. And if you really try, you'll find there's no need to cry. In this place, you feel there's no hurt or sorrow. There are ways to get there if you care enough for the living. Make a little space, make a better place. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me. If you want to know why, there's a love that cannot lie. Love is strong, it only cares for joyful giving. If we try, we shall see. In this bliss we cannot feel. There are dreams, we stop existing and start living. Then it feels that always love's enough for us growing. Make a better world, make a better world. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for living, make a better place for you and for me. And the dream we weren't conceived in will reveal a joyful face. And the world we once believed in will shine again in grace. Then why do we keep strangling when this earth crucify its soul? Though it's plain to see this world is heavenly. Be God's love. We could fly so high, let our spirits never die. In my heart, I feel you are all my brothers. Create a world with no fear. Together we'll cry happy tears. See the nations turn their swords into plowshares. We could really get there if you cared enough for the living. Make a little space to make a better place. Heal the world, make it a better place for you and for me and the entire human race. There are people dying. If you care enough for the living, make a better place for you and for me. Heal the world, make it a better place for you and for me and the entire human race. There are people dying.
kang matakot. Di mo ba alam, nandito lang ako sa iyong tabi. Di kita pababayaan kailanman. Ako, ikaw ay mahulog sa bangin, ay sasaluhin kita.
Huwag kang matakot na matulog mag-isa, kasama mo naman ako. Huwag kang matakot na umibig at lumuha, kasama mo naman ako. Huwag kang matakot.
Huwag kang matakot, di mo ba alam, nandito lang ako sa iyong tabi. Di kita pababayaan kailanman.
At kung ikaw ay mahulog sa bangin,
ay sasaluhin kita.
Huwag kang matakot na matulog mag-isa, kasama mo naman ako. Huwag kang matakot na umibig at lumuha, kasama mo naman ako. Huwag kang matakot.
Huwag kang matakot, dahil ang buhay mo'y walang katapusan. Makapangyarihan ang pag-ibig na hawak mo sa iyong kamay. Ikaw ang Diyos at Hari ng iyong mundo. Matakot sila sa iyo. Huwag kang matakot na matulog mag-isa, kasama mo naman ako. Huwag kang matakot na umibig at lumuha, kasama mo naman ako.
Huwag kang matakot na agad magpabakuna, kasama mo naman ako. Huwag kang matakot sa COVID na di mo nakikita, kasama mo naman ako. Huwag kang matakot.
Huwag kang matakot, di mo ba alam, nandito lang ako sa iyong tabi. Di kita pababayaan kailanman.
Huwag kang matakot,
huwag kang
matakot kailanman.
Huwag kang matakot, di kita pababayaan kailanman.
Huwag kang matakot, di kita pababayaan kailanman.
Huwag kang matakot, di kita pababayaan kailanman. pananggayanin sa bawat nilalang magigising ang lupang kulang sa dilim. Ikaw ang magsasabing kaya mo to, tulad ng isang tanglaw sa gitna ng bagyo. Ikaw mo sa hangin tumitig at magsilbi, liwanag, liwanag sa dilim. Harapin mong magiting ang bagong awitin. Ikaw ang liwanag sa dilim. At sa paghamon mo sa agos ng ating kasaysayan, uukit ka ng bagong daan. Oh, 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 ikaw ang naawit ng kaya mo to, sampahan namin sa gitna ng mundo. Isigaw mo sa hangin, tumitig at magsilbi, liwanag, liwanag sa dilim. Harapin mo, magiting ang bagong awitin. Ikaw ang liwanag. Isigaw mo sa hangin, tumitig at magsilbi, liwanag sa dilim. Ang bagong liwanag. Isigaw mo sa hangin, tumitig at magsilbi, liwanag sa dilim. Harapin mo, magiting ang bagong awitin. Liwanag sa dilim. Liwanag sa dilim. Liwanag.
Wow, ang bagsik! Ang bagsik ng presentation. Liwanag sa dilim. Yeah. So, okay. So, we'll be welcoming back Dr. Sir Mike, Dr. Mike Tawenko, Dr. Yakapin, and Dr. Carrion. We will be now presenting the winners, or we'll be awarding the certificates saka yung ano po, mga plaques sa ating mga nanalo sa contest po.
Okay, so we are to announce the winners of the third interesting case presentation of the PCS and PSGS Southern Tagalog chapter. I'd like to say good evening. Dr. Alex Palines, the chairman of Department of Surgery of PAT-MC is here. Good evening, sir. Dr. Arvin Briones is here, PCS President, Southern Tagalog Chapter. Sir, good evening.
Good evening, Mike.
Sir, good evening. There's a Dr. Berberabi also here, Training Officer of PAT-MC. Good evening, sir. Okay, so let's present our winners. Second runner-up muna. Can we flash?
For the guest participants, sir.
Guest participant. Oo nga pala.
Sorry, sir.
So for the guest participant, we have one guest participant. A plaque of recognition is given to our guest winner, Osmoon, Hospital ng Muntinlupa for laparoscopic cystectomy with omentopexy for recurrent non-parasitic hepatic cyst. A case report and literature review by Dr. Carmen Argelies. Doctora, congratulations.
Thank you po.
And the next winner is the second runner-up, no? Second runner-up goes to General Emilio Aguinaldo Memorial Hospital for soft tissue and left temporal bone Langerhans cell histiocytosis in a 1-year and 7-month-old Filipino male. A case report by Dr. Kevin Matthew Roderno. Congratulations, Dr. Kevin.
Thank you po, sir. Thank you po.
The next winner will be the first runner-up. The first runner-up will also receive a 5,000 peso cash prize. So the first runner-up is it goes to De La Salle University Medical Center. Mistaken identity. A case of appendiceal mucinous neoplasm presenting as an ovarian new growth by Dr. Joanne Celestine Trajano. Joanne, congratulations.
Thank you, sir.
Sige po, sir.
And the next winner will be called the first place. So the first place winner will also receive a cash prize at the amount of 7,000 pesos. So the first place goes to University of Perpetual Health Consortium, spontaneous splenic rupture on a pulmonary arteriovenous malformation patient by Dr. Kenneth Gerson Lumban. Congratulations, Dr. Kenneth. And the champion, there's a champion trophy that is circulating. It is currently in De La Salle University Medical Center. And the champion will also win a cash prize of 10,000 pesos. So for this year's interesting case category, the champion for the Southern Tagalog region is Batangas Medical Center, calvarial tuberculosis presenting as a lytic lesion of the skull in a 15-year-old male. Case report by Dr. Rubilin Casao. Congratulations, Dr. Rubilin.
Thank you po, sir.
So congratulations to all the winners. And yes, I give it to you, Janet.
Yes, sir. Thank you. Congratulations again to everyone. Prizes to be sent to all the institutions and the winners. Thank you to you.
Okay. So thank you, Sir Mike, Sir Clars, Ma'am Janet. Maraming salamat po for presenting our tonight's winners po. And for the closing remarks, we'll call on Dr. Jasmine Andaman, our PSGS Vice President. Doctora. Hello, ma'am.
Good evening, doctors. I would like to thank the organizing committee for a successful event tonight. And I would like also to thank the judges for joining us this evening. And to all the winners, congratulations for a very job well done. Thank you all for joining us tonight. And again, good evening. Thank you.
Thank you, Dr. Jasmine. Maraming salamat po. And before we wrap up everything, so we'll be having our PCS ST Southern Tagalog chapter hymn.
Further south, land of heroes in history, men with courage and lineage. Specialty is surgery, Batangas, Cavite, Laguna, Quezon, Mindoro. We are here to serve people and community. Be a fellow, step up to see part of the future in history. And a vision and compassion. Your specialty is surgery. Batangas, Cavite, Laguna, Quezon, Mindoro. We are here to serve people and community. We are surgeons, united we are one. We are surgeons of this chapter, together we are one. We are fellows, Southern Tagalog, in PCS we are one. We are one. Surgeons, united we are one. We are surgeons of this chapter, together we are one. We are fellows, Southern Tagalog, yes we are one. We are surgeons, Southern Tagalog, yes we are one. We are one.
All right. So that wraps up yung ating first night sa out of 3. So next week, meron po sir, meron po kayong share sir, Sir Mike.
Yes, can we have a picture taking?
Apo.
Open your cameras just for documentation. Kaya mo picturean, Janet. Cute na aso ni Janet.
Picture, yeah.
Okay, please open your camera. Smile. Wait, sorry. 1, 2, 3. Okay, page 2. Sorry, may gustong sumama. Please open your cameras. Thank you. Okay, 1, 2, 3. Smile. And page 3. Can we ask the students and the residents to open their cameras, please? Okay, thank you.
Thank you, Dr. Janet. Yeah, we are one.
Thank you.
Thank you po sa lahat. So,
I'll just make an announcement. The next research contest will be moved to November 23. It will be a fusion of descriptive and analytical. So next week, wala muna tayong contest, but it will be moved to November 23 for 6 submissions. Okay. So yun lang, I'll just post it na lang in the Viber groups. And can we ask the officers to stay for a while to discuss for the next contest? Saglit lang.
Thanks, Mike. Bye.
Yes, sir.
Thank you. Thank you.
Judges, thank you po.
Mr. President, thank you.
Thank you po, judges.
Thank you.
Judges po.
Participants,
Si Mike pala, meron
sobrang
niyang
thank
hidden
you.
talent si Mike. Magaling yan sumayaw para sa next. Baka may mga program kayo sunod. Magaling yan
Ano ba?
sumayaw. Thank you.
Winners, congratulations.
Congrats to the winners.
Sige po, pwede na pong mag-exit yung presidents, students. Thank you po for joining us next week and November 23. Let's kita-kita po ulit.
Okay. Good evening. Update ko lang po kayo sa yung naging dilemma namin for the descriptive and the analytical is yung number of submissions. We only have 2 submissions for descriptive and 1 for analytical. So we talked with the research committee. Since first time naman gagawin yung descriptive and analytical, to increase para lang matuloy and we increased the submissions by allowing, just for the descriptive and analytical, allowing the institutions to submit more than 1 research paper per category. We'll just be asking the training officers, and we will be moving the date of the descriptive to 23 in time for the judges to study all the submissions. If ever kasi, ang mga magsasubmit na lang sa descriptive and analytical would be Batangas, Perpetual, and Lasal because JAM and Mary Mediatrics wala pa silang mid-year level residents that do the descriptive studies. So if ever magiging Clarence 4 ang submissions for descriptive.
Yes, sir.
And